Good evening. I hope I'm audible. If I'm audible, can I see a thumbs up in the chat, please? Yeah, good evening, Prachi. Hi, Professor. Hi, Dark Trading. So if you're joining the session, thank you. So if you're joining the session for the first time, this is Dr. Shanmugapriya. I'm Professor and Head of the Department of Biochemistry at Government Thoothukudi Medical College, and I'm your Unacademy educator for Biochemistry. And today's session, it's an image-based question session. It's purely on biochemistry. Yeah, thank you. And I will be discussing few MCQs related to disorders, few MCQs related to graphs, and few to pathways. Okay, so that's a plan for today's session. And before we start the session, let me tell you few facts about Unacademy plans. Special class features include interactive live sessions. You will be able to participate in polls, and using the raise a hand option, you will be able to interact with the educator one-on-one, and you can get your doubts clarified real time. And apart from this, there are multiple free tests which are happening. Test series are happening throughout on Unacademy platform. So I recommend that you take up as many tests as possible, because that will help you understand where you stand. And plus subscription gives you an access to both live and recorded sessions. It also gives you an access to a question bank with 25,000 plus clinical case based MCQs. And all these questions are framed based on the latest pattern. Iconic subscription gives you an access to both Unacademy and PrepLadder platform. And if you have either a plus subscription or iconic subscription, you can access any of the structured batches which are happening currently on Unacademy platform. So if you're an FMG aspirant, we have FMG 2022 High Yield Revision and MCQ batch. It is about to start. It's starting on March 23rd. The duration would be 2 months. And in this batch, all 19 subjects will be discussed in detail. And it will also include subject-wise tests and grant tests. And these are the toppers in the latest FMG December 2021. The highest was 217, followed by 209. And if you're a NEET PG aspirant, see, these are the toppers in the latest NEET PG September 2021. And for NEET PG aspirants, we have a NEET PG 2022 High Yield MCQ Marathon batch. And this is also starting on March 23rd. The duration is also 2 months. And this is the current NEET PG subscription plan. If you're opting for plus subscription, the minimum that you can choose is 2 months, and that would cost you 7,650. Good evening, Ipsita. And if you are looking for iconic subscription, that will the minimum duration that you can opt for is 6 months, and that would cost you 36,000. Light subscription is nothing but you accessing only test papers and discussions. So the duration would be 2 months, and that would cost you 2,160. And all this costs are inclusive of 10% discount. And to get 10% discount, you can use any educator's code. My code is C Shanmugapriya or Biochem Live. You can use one of these two codes if you want 10% off. So that's all about Unacademy plans. Let's now start discussing MCQs. So have you seen this question? Yeah, this is a NEET PG question. A 7-year-old girl presents with bilaterally symmetrical discrete papules with central keratinous plug. Do you see keratinous plugs here? Yeah, localized to elbows as shown in the image. The probable cause is deficiency of. Is it because of deficiency of retinol, retinal, retinoic acid, or vitamin D? Can any one of you give me the right answer? First tell me, what is the diagnosis here? What is the dermatological diagnosis here? Dermatological diagnosis is, come on all of you, phrenoderma, right? It is basically phrenoderma, and we all know phrenoderma is caused by a deficiency of vitamin A. But the question is, they are asking you, is it because of retinol, retinal, or retinoic acid deficiency? That is the question. So you have to know about the various forms of vitamin A. Can you tell me what are the 3 forms of vitamin A? Yeah, one is retinol, OL. The second one is retinal, aldehyde form. And the third one is retinoic acid. And of the 3, retinol, the alcohol form is the form in which vitamin A is digested. It is absorbed and transported. Yeah, the OL form, the alcohol form is the form in which vitamin A is absorbed. That is the form in which it is transported. That is the form in which it is stored. Suppose the question is, in what form is vitamin A stored in liver? What will be your answer? Your answer should be retinyl palmitate, or in other words, retinol attached to palmitic acid. Retinal. Do you see a retina here? Retinal. Do you see a retina here? That's a clue that is given to you. This is the form that is present in eye. In rods and cones, you have retinal in the form of Levensis retinal. Until the rhodopsin or conopsin are stimulated by light, it is Levensis retinal. So retinal is the form that is present in rods and cones. Now retinoic acid, there are two forms of. Audio volume is a bit low. Is that true? Is the audio volume low? Can anybody give me an input on this? Yes. It's fine. Okay. Okay. So retinoic acid, there are two forms of retinoic acid. One is all trans retinoic acid. The other one is 13-cis retinoic acid. All trans retinoic acid helps in growth and differentiation of cells. Please memorize it. All trans retinoic acid, but very low. 1 second. How is the volume now? Am I audible? Am I audible now? Am I audible now? Okay. Okay. So I was telling about all trans retinoic acid. So all trans retinoic acid helps in growth and differentiation of cells. Whereas 13-cis retinoic acid suppresses keratinization of epithelium. Please memorize it. 13-cis retinoic acid suppresses keratinization of epithelium. That is why whenever there is vitamin A deficiency, when there is low 13-cis retinoic acid, there is keratinization of epithelium happening everywhere. And keratinization of conjunctiva causes conjunctival dryness. What do you call conjunctival dryness as? Xerosis. So what is the reason for conjunctival dryness or xerosis? It is because of keratinization of conjunctival epithelium. And the keratin plug, yeah, the keratin that accumulates, keratin debris will accumulate as Bitot spots. And keratinization also happens in cornea, right? And that causes corneal drying and keratomalacia. So all these are because of keratinization. All these are because of keratinization of epithelium. And keratinization of skin is the reason for phrenoderma. Yeah, that is why do you see that there are keratin plugs in the tip of those papules. So your answer should be 13-cis retinoic acid. So the carry home message here is the alcohol form retinol is the form in which vitamin A is absorbed, it is transported, it is stored. Retinal, the aldehyde form, is the form in which it is present in rods and cones. Retinoic acid, all trans retinoic acid helps in growth and differentiation of cells. And 13-cis retinoic acid suppresses keratinization of epithelium. So the answer here is retinoic acid. To be very specific, it is 13-cis retinoic acid. Okay. Now this is the next question. A 15-year-old boy presented to the ophthalmology department with an acute reduction in visual acuity in both the eyes. So spontaneous reduction in the visual acuity in both the eyes. The direct observation of both the eyes is shown here. Do you see that here? And do you see that there is dislocation of lens? Yeah, where is the lens dislocated? It is superotemporal dislocation of lens. So can anyone tell me what would be the most common cause of spontaneous superotemporal dislocation of lens? Yes, it is Marfan syndrome. Very good, Sai Kiran. It's Marfan syndrome. The ophthalmologist also has suspected Marfan syndrome and he has ordered for genetic testing, which revealed FBN1 gene mutation, fibrillin gene mutation causes Marfan syndrome. Which of the following is true about the disorder and the protein involved? They are not asking you to make a diagnosis. They've given you the diagnosis. They are asking you about feature of fibrillin gene. The protein reduces TGF beta levels. Alpha 2 agonists delay the progression of the disorder. It's an autosomal recessive disorder. Yes, fanning out of lens. Good. It's an autosomal recessive disorder. The protein involved reduces the elasticity of tissues normally. What do you think is the right answer? Guru says it's choice C. It's not choice C because Marfan syndrome is autosomal dominant. Can anyone else give me another answer? It's an autosomal dominant condition. D. The protein involved, fibrillin protein, reduces the elasticity of tissue normally. No. Fibrillin actually increases the elasticity of tissues normally. That is why what happens in Marfan's? In Marfan's, the elasticity is lost. When the lung loses its elasticity, when the person inhales, that is air trapping. Do you know that? Only when the lung is elastic, what will not happen? Air trapping will not happen. So in Marfan syndrome, because there is reduction in the elasticity, inhalation happens, but exhalation does not happen. So there is air trapping and that is why it causes bulle and pneumothorax. One of the complications of Marfan syndrome is bulle and pneumothorax. That should tell you that the normal protein improves the elasticity. Do you all understand that? Okay. And very good, Paulami Das. Yes, as Paulami Das has answered, yes, fibrillin 1 protein reduces TGF beta levels. This is a correct statement. Okay. So can we learn all about Marfan syndrome? Before we start learning about Marfan syndrome, what was your observation? Your observation was bilateral superotemporal dislocation of the lens. And Marfan syndrome will most commonly present with bilateral supratemporal dislocation of lens. And the most common cause of this is also Marfan syndrome. Okay. And what is Marfan syndrome? It's an autosomal dominant condition. All of you please memorize it's an autosomal dominant condition. It is caused by a mutation of FBN1 gene. It is caused by a mutation of FBN1 gene which is present in chromosome 15. And this gene codes for a protein called as fibrillin protein. Now, what is the function of fibrillin protein? Listen to this carefully. Fibrillin protein helps in forming microfibrils in connective tissues. What do they help in? They help in forming microfibrils in connective tissues. And here fibrillin is either associated with elastin or sometimes it's not associated with elastin. And whenever fibrillin is associated with elastin, it increases the elasticity of the tissues. Yeah, whenever it is an association with elastin, it improves the elasticity of tissues. Example is, this is the form of fibrillin that is present in skin. This is the form of fibrillin that is present in lungs and in blood vessels. So in association with elastin, where is it present? Yes, Nitya, you're right. I will tell you about this. In homocystinuria, it is infranasal dislocation. Okay. So with elastin, it improves elasticity and that is the form of fibrillin that is present in skin, lungs and blood vessels. Without elastin, it supports the tensile strength. Yeah, whenever it is not associated with elastin, it supports the tensile strength. And this is the form of fibrillin that is present in tendons. And this is the one that is also present in suspensory ligaments of limb. Without elastin, it supports a tensile strength. That is how it is present in tendons and in suspensory ligaments of limb. And the third function of fibrillin gene is that it reduces TGF beta levels. The third function of fibrillin protein is that it reduces the levels of TGF beta. And what is the actual function of TGF beta? There are many functions of TGF beta, but one of the functions is that it causes necrosis. TGF beta causes necrosis of cells. Okay. Now tell me what will happen whenever there is fibrillin gene mutation and these proteins are not functional. When these proteins are not functional, elasticity is lost. Then lung is PDF available. I will share the PDF in the Telegram group and in the community cycle. I will share it. So don't write it. I will share it. Okay. So when it is when this fibrillin gene is mutated and fibrillin protein is inactive, there is a decrease in the elasticity of tissues. And when lung loses its elasticity, there is air trapping, and that is why it causes bullae and pneumothorax. And when blood vessels lose their elasticity, blood vessels are dilated, okay, and that causes regurgitation, that causes aortic regurgitation, mitral valve prolapse. And I told you TGF beta causes necrosis. Now what happens in Marfan syndrome? In Marfan syndrome, there is no reduction in TGF beta. So there is excessive necrosis. Whenever there is cystic medial necrosis along with aortic regurgitation, when there is cystic medial necrosis, that causes aortic dissection. So what is the Telegram group? Telegram group, you can search for me as Biochemistry Dr. C. Shanmugapriya. Yeah, search as Biochemistry Dr. C. Shanmugapriya. So cystic medial necrosis happens and that causes dissection of aorta. Okay. And when the tensile strength is reduced in the tendon, when there is no tensile strength, that causes arachnodactyly. And when suspensory ligaments of limb are not that strong, what happens to lens? Lens gets dislocated. And that is why what form of dislocation you find? There is superotemporal dislocation of the lens. And at this point, as one of you had answered it, there is infranasal dislocation. Infranasal dislocation of lens is observed in homocystinuria. So have you understood all this? Yeah, so what are the facts I've told you about Marfan syndrome? Marfan syndrome is an autosomal dominant condition caused by a mutation of FBN1 gene, in chromosome 15. And FBN1 gene codes for fibrillin. Fibrillin helps in forming microfibrils and connective tissues. What are the functions of fibrillin? In association with elastin, it supports elasticity of tissues, particularly in skin. It supports elasticity of lungs. It supports elasticity of blood vessels. And that is why in Marfan syndrome, you find bullae pneumothorax. And when blood vessels are dilated, it causes aortic regurgitation, mitral valve prolapse. And the third function of fibrillin is that it suppresses TGF beta levels. And when fibrillin is mutated, TGF beta level will increase. An increase in TGF beta will cause necrosis. And cystic medial necrosis causes aortic dissection. Now do you understand why we give beta blockers for a patient of Marfan's? A patient of Marfan's is given what? Yeah, what do we give in Marfan syndrome? In Marfan syndrome, you give beta blockers and we give losartan. So why do we give beta blockers and losartan? Because both beta blockers and losartan can reduce TGF beta levels. Thereby we are suppressing necrosis. Thereby we are delaying that the patient presents with aortic dissection. So tell me, what is the treatment that is provided for Marfan syndrome? For Marfan syndrome, it's beta blockers and losartan, which reduces TGF beta levels, which delays aortic dissection. Okay. And without elastin, what do? They support the tensile strength, and that is how it supports the tensile strength of tendons and suspensory ligaments. So when there is Marfan syndrome, there is no tendon tensile strength that causes arachnodactyly. Suspensory ligaments are not that strong. How can they decrease TGF beta? Is that your question, Sai Kiran? It is because beta blockers and losartan reduce TGF beta. You try reading pharmacological effects. Thank you. In has written the name. So TGF beta levels are reduced by both beta blockers and by losartan. Please read pharmacological effects of these two drugs. You will see that they reduce TGF beta levels. Okay. So that is why there is superotemporal dislocation of lens in Marfan syndrome. So can we discuss the differences between Marfan syndrome and homocystinuria? I want all of you to be active during this discussion. The first difference between Marfan's and homocystinuria is inheritance. Marfan's is autosomal dominant, homocystinuria is autosomal recessive. And what is the gene that is mutated in Marfan syndrome? That's just now I told you. Marfan syndrome is caused by a mutation of fibrillin 1 gene in chromosome 15. There is homocystinuria. There are multiple causes of homocystinuria, but type 1 homocystinuria, which is more common, is caused by a defect of cystathionin beta synthase. It is caused by a mutation of cystathionin beta synthase in chromosome 21. Very good. I'm happy that all of you are active. Homocystinuria is caused by a mutation of cystathionin beta synthase in chromosome 21. Lens dislocation. Tell me what is the direction of dislocation of lens in Marfan syndrome? Marfan's, it is superotemporal dislocation. In homocystinuria type 1, it is infranasal dislocation. And then joints in Marfan syndrome, it is a hyperextensible joint. Yeah, it's a hyperextensible joint in Marfan's. Whereas in homocystinuria, the joint movement is restricted. Joint movement is restricted in homocystinuria. And then blood vessels, Marfan syndrome will present with dilatation of blood vessels, whereas homocystinuria, they present as vaso-occlusive disease. You know that type 1 homocystinuria, they present with accelerated atherosclerosis. They present with accelerated thrombosis, right? Young patient presenting with MI, young patient presenting with stroke, that is when you're going to suspect homocystinuria. So homocystinuria presents as what? It presents as vaso-occlusive lesion, whereas Marfan's will present with vasodilatation. Okay. And treatment. What is the treatment that is given for Marfan's, all of you? Yes, early onset thrombosis. Very good in. So what is the treatment for Marfan's? For Marfan's, just now I told you beta blockers and losartan. They are provided, and the main function of this is, what is the main purpose of giving beta blockers and losartan? Thereby we are trying to reduce TGF beta levels. And what is the treatment given for homocystinuria? If it is type 1, we prescribe pyridoxal phosphate. If it is type 2, we prescribe B12 and folate. Type 1, it is pyridoxal phosphate. Type 2, we give B12 and folate. So are you clear about the differences between Marfan's and homocystinuria? Yeah. So this is the tabular column that I will provide you in the provide you as a PDF. Okay, in the Telegram group. So download this and read it thoroughly. So what are the differences between Marfan's and homocystinuria? Marfan's is autosomal dominant, homocystinuria is autosomal recessive. The gene mutated in Marfan's is fibrillin 1 gene, FBN1 gene of chromosome 15. Whereas in type 1 homocystinuria, it is cystathionin beta synthase of chromosome 21. Dislocation of lens in Marfan's, it's superotemporal dislocation. In homocystinuria, it's infranasal. Joint mobility, hyperextensible joints in Marfan's, whereas it is restricted movement in homocystinuria. Vascular defects, it is vaso-occlusive disease as far as homocystinuria is concerned, whereas in Marfan's, the blood vessels are dilated. And treatment is for Marfan's, it's beta blockers and losartan. Homocystinuria, if it's type 1, it is B6. If it's type 2, we give B12 and folate. So can you now give the answer for this question? All of the following are true about fibrillin protein except, does this protein reduce TGF beta levels? They're asking you which of the following is true. Yes, fibrillin 1 reduces TGF beta levels. Tell me about choice B. Do you give alpha 2 agonists? Do you give alpha 2 agonists to delay the progression of the disorder? No. What do you give? You give beta blockers. So B is false. Is it an autosomal recessive disorder? No, it is autosomal dominant disorder. The protein involved reduces the elasticity of tissues normally. False. Why is there restricted joint mobility in homocystinuria? It is because it intercalates with collagen fibers. Yeah, it intercalates with collagen fibers and it restricts the mobility. Yeah, that's the reason. The next question, a 53-year-old person who is treated for pyelonephritis suddenly presents with an acute abdominal pain. So the clue that is given to you is upper urinary tract infection. Following that, the person is presenting with an acute abdominal pain. Ultrasound reveals a large stone. Lithotripsy is done and the microscopic visualization of the stone is 1 second. So microscopic visualization of the stone is shown in the image. What is the chemical composition of the stone? What do you think is the right answer? Some of you have answered it as choice C, calcium oxalate. In has answered it as magnesium ammonium phosphate. Very good, In. I'm very happy. In has given all the right answers. So can we first describe this? Can anybody tell me how will you describe the appearance of the stone? Doesn't it look like a coffin lid? Yeah, answer is magnesium ammonium phosphate. Very good, Dr. House. Very good, Varsha. Very good, Aruna Devi. There is a beep frequently. 1 second. So can you hear me now? Am I audible? Okay. So how will you describe this, all of you? I've done it. I've done it, Giri. Answer this. How will you describe this? You describe it as coffin lid appearance, right? And coffin lid appearance is a feature of struvite stones. Yeah, and do you know that struvite stones is the most common cause of staghorn calculus? Struvite stone is the most common cause of staghorn calculus. So don't you know that staghorn calculus is nothing but the entire pelvic calyceal system is blocked with renal stone. Is it a milder condition or a severe condition? It's a severe condition. And if it's severe, you should link it to coffin lid. Okay, so coffin lid appearance is a feature of struvite stones, and struvite stones are more notorious to cause staghorn calculus. And what is the most common cause of struvite stone? Struvite stones appear whenever there is an alkaline pH in the urine, and alkaline pH of urine is observed whenever there is upper urinary tract infection. So whenever there is upper urinary tract infection caused by urease producing microorganisms, urease will convert urea that is present in urine to form ammonia that causes alkaline pH. And this alkaline pH causes struvite stones. And what is the nature, chemical nature of struvite stone? It is MAP. You can remember it as MAP. And what does MAP stand for? MAP stands for magnesium ammonium phosphate. You call it as triple phosphate, but remember it is MAP, which is magnesium ammonium phosphate. So what are the facts that you have learned here? Coffin lid appearance is a feature of struvite stones. Struvite stones are more notorious to cause staghorn calculus, and struvite stones appear whenever there is upper urinary tract infection caused by urease producing microorganisms like Proteus. And the chemical nature of struvite stone is MAP. What does MAP stand for? Magnesium ammonium phosphate. So can we learn about the other forms of stones? Yeah. So describe the stone, please. How will you describe the appearance of the stone? It has got 6 sides. So it is a hexagonal stone. And hexagonal stone is a feature of cystine. Yeah, cystine stones are hexagonal. And when will you find cystine stones? Whenever there is cystine urea. What is cystine urea? Whenever there is a defect of a neutral amino acid transporter that is responsible for reabsorbing 4 amino acids along the renal tubule. So what are the 4 amino acids that are reabsorbed through that common amino acid transporter? Those 4 amino acids can be remembered as CoLA. What does CoLA stand for? Cysteine, ornithine, lysine and arginine. So when that neutral amino acid transporter is defective, cysteine, ornithine, lysine and arginine will be found in the renal tubular fluid. Supersaturation of cysteine, when there is excess cysteine, cysteine will form disulfide bridges and it becomes cystine. Cystine is insoluble in urine, so cystine gets deposited in the renal tubule causing cystine stones. So all of you tell me about cystine urea. What will cystine urea present us? Cystine urea will present us recurrent renal stones, and those renal stones are hexagonal. And how do we remember it? Cystine, don't you think it sounds like 6? Yeah, cystine, don't you think it sounds like 6? 6 is hexagonal. So hexagonal crystals are nothing but cystine crystals, which is a feature of cystine urea, which presents as recurrent renal stones. Okay. Now describe this. How does it look like? Don't you think it looks like an envelope? Yeah, it looks like an envelope. So envelope shaped crystals. Yeah, envelope shaped crystals. Do you see X in the center? In envelope shaped crystals, do you see X in the center? That is a clue that is given to you that envelope shaped crystals are nothing but calcium oxalate crystals. They are nothing but calcium oxalate crystals. And you find calcium oxalate crystals whenever there is low availability of citrate. For any reason, if there is low availability of citrate in the tubular fluid, that precipitates calcium oxalate formation. Okay. And how do we remember it? It is X. Yes, you're right. Dihydrate, calcium oxalate dihydrate. Letter kept side by side, reverse becomes hexagonal. Okay, so envelope shaped is X. Yes, calcium oxalate dihydrate. You're right. And then how do we describe this? Can we describe this as rectangular? Yeah, this is rectangle and this is rhomboid. So rectangular or rhomboid crystals, they are features of uric acid crystals. Uric acid. How do we remember it? Uric, U is written like this, right? So when you close it, it is rectangular, or U can be written like this. So it is rhomboid. So rectangular or rhomboid crystals are features of uric acid crystals. So it is found in hyperuricemia. Okay. So can we fill up this tabular column? I want all of you to answer this. So the first shape about which I told you is coffin lid. So coffin lid is something severe. Which is severe? Struvite stones are severe. And what is the chemical composition of struvite stones I told you? Chemical composition of struvite is MAP. What does MAP stand for? Magnesium ammonium phosphate. And condition, when do you find coffin lid crystals or struvite crystals? Struvite crystals are observed whenever there is alkaline pH of urine, that is observed following upper urinary tract infection caused by urease producing microorganisms. And the second one which I showed you is, which is the second one I showed you, hexagonal crystals. Yeah, hexagonal is 6. And that is a feature of which one? Cystine. Yeah, it's a feature of cystine stones. Condition is cystine urea, wherein there is a defect of a neutral amino acid transporter which reabsorbs cysteine, ornithine, lysine and arginine. And then envelope shaped crystals. Yeah, envelope shaped crystals. In the center there is an X. X stands for calcium oxalate. It stands for calcium oxalate. In which condition do you find calcium oxalate crystals? Whenever there is low citrate that is available in the tubular fluid. And the last one, which is the last one? Cystine urea detection. What do you mean by that? And the last one is rectangular or rhomboid crystals. Rectangular rhomboid crystals, chemical composition is uric acid. What is the condition when you find this? It is hyperuricemia. Okay, so that's all about renal stones images. So it is coffin lid appearance which is seen in magnesium ammonium phosphate. Answer this all of you. If you're asking how do we diagnose cystine urea, is that your question, Bhuvanashri? How do we diagnose cystine urea? It is by chromatography. Chromatography of urine, urinary chromatography will detect the presence of all 4 amino acids in excess quantity in urine. Okay. So the most probable antibody detected in this condition is, can you answer this? Antithyroglobulin antibody. Sai Kiran says its choice B. Aruna Devi, antithyroglobulin antibody. So most of you are answering it as antithyroglobulin and some of you have answered it as choice D. So can we exclude choice B and choice C? Anti-gliadin antibody and anti-transglutaminase antibody, they are present in celiac sprue. Yeah, they are present in celiac sprue. So first, can we describe all these pictures? So what are the pictures that you see here? Do you see a goiter here? Yeah, you see a goiter here, and this is exophthalmos. Goiter with exophthalmos. And then what is this? This is pretibial dermatopathy. Yeah, this is pretibial dermatopathy. This is acropathy, which is nothing but clubbing. Yeah, acropathy, which is nothing but clubbing. So what are the features that you find here? There is goiter, there is exophthalmos, there is pretibial dermatopathy, there is acropathy. And I'm going to exclude antithyroglobulin antibody here because antithyroglobulin antibody is observed in Hashimoto's. Yeah, it is observed in Hashimoto's. And in Hashimoto's, will you find exophthalmos, all of you? Is Hashimoto's characterized by exophthalmos? No, right? Hashimoto's, of course, will present with goiter. It can present with myxedema. Yes, this can look like myxedema. Yeah, but it is not going to present with exophthalmos. So if you see exophthalmos, goiter, pretibial dermatopathy and acropathy, what should you suspect? You should suspect Graves' disease. So what is Graves' disease, all of you? Graves' disease is an autoimmune disorder wherein autoantibodies are directed against TSH receptors. Autoantibodies are directed against TSH receptors, and the effect of these autoantibodies binding onto these TSH receptors is that these TSH receptors are made hyperfunctioning. So tell me what will happen when on the thyroid gland TSH receptors are working more. Thyroid gland will undergo hyperplasia, and thyroid gland hyperplasia will cause goiter. That is why, do you remember the image showed goiter? And it will not only cause thyroid gland hyperplasia, it will also stimulate thyroid glandular cells to release more hormones. So tell me what will happen when more hormones are released. That will cause thyrotoxicosis. So usually when do you find goiter in a patient? Usually you find goiter in a patient of hypothyroidism. Yes or no? Usually you find goiter in a patient of hypothyroidism because only when there is low FT3 and FT4, that can be feedback stimulation of TSH and that TSH will cause thyroid gland hyperplasia that causes goiter. So usually you find goiter in a patient of hypothyroidism. But if you find goiter along with hyperthyroidism, what will be your suspicion? Yeah, you will suspect Graves' disease. Okay. And apart from this, these antibodies, these autoantibodies, they don't only go and bind to TSH receptors here. They also cross react. These autoantibodies also cross react with TSH receptor analogs which are present in the pre-adipocyte fibroblasts. These antibodies also go and cross-react with TSH receptor analogs which are present in the pre-adipocyte fibroblasts. And some of these pre-adipocyte fibroblasts are present in retroorbital tissues. So retroorbital tissues, fibroblasts get activated, they release cytokines. And these cytokines will cause edema. So tell me what will happen when there is retroorbital edema? That causes exophthalmos. Yeah, so what is the reason for exophthalmos in Graves' disease? It is because autoantibodies, they cross-react with TSH receptor analogs which are present in pre-adipocyte fibroblasts. These fibroblasts are present in retroorbital tissues. So in retroorbital tissues, when fibroblasts get activated, they release cytokine that causes exophthalmos. And fibroblasts are also present in the tibial tissues. So that causes pretibial dermatopathy. And cross reactivity of antibodies on fibroblasts which are present in the periphery. In the periphery, there edema happens and that causes clubbing. Okay. So these are the manifestations of Graves' disease. So what are the facts that you have learnt about Graves' disease? When will you suspect Graves' disease? Whenever you find hyperthyroidism along with goiter. Do you understand this? Whenever you find hyperthyroidism along with goiter, and additionally, if you find exophthalmos, pretibial dermatopathy, acropathy, you should think of an autoimmune disorder, which is Graves' disease. Now, what are the autoantibodies that you find in Graves' disease? Those autoantibodies are called as long-acting thyroid stimulator antibodies. Yeah, what do you call them as? Long-acting thyroid stimulator antibodies, shortly called as LATs. Okay, so what is answer? Yeah, what is answer, all of you? The answer is long-acting thyroid stimulator. Thank you, Guru. It is choice D. So this is the next question. A 42-year-old man presents with hypoglycemia. He is a known patient of tuberculosis with poor adherence to treatment. He was treated with dextrose, and before discharge, he wanted a dermatological opinion for hyperpigmentation of gums. Do you see hyperpigmentation of gums, tongue and joints? Yeah. In all these places, there is hyperpigmentation. The dermatologist suspected Addison's. The cause of hyperpigmentation Addison's disease is. What is answer? Sai Kiran says it's choice C. Megha Bimani also thinks it's choice C. In says it's choice C. Dinesh also says it's choice C. Very good. So the answer here is choice C. Ankit thinks it's choice B. Okay, answer is choice C. ACTH and MSH are synthesized from pro-opio melanocortin. So using this question, what are the facts that you're going to learn? Yeah, using this question, I want you to remember that Addison's. What is Addison's? Addison's is adrenal cortical failure. And one of the causes of adrenal cortical failure is post-tuberculosis. Tuberculosis mediated destruction of adrenal cortex. So can you see that here? A patient of tuberculosis with poor adherence to treatment. So tuberculosis can affect adrenal cortex, can present as Addison's. And the second fact that you should observe here is Addison's patient present with an episode of hypoglycemia. Addison's patients often present with an episode of hypoglycemia. They also present with hyperpigmentation. So let me tell you all that you need to know about Addison's. Addison's is nothing but adrenal cortical failure, and it is caused by either autoimmune mediated destruction of adrenal cortex, or it is caused by tuberculosis mediated destruction. So tell me, what are the two common causes of Addison's? It's either autoimmune destruction or it is tuberculosis mediated destruction. In either case, when adrenal cortex is spoiled, what will happen to cortisol secretion, aldosterone secretion? Yeah, what will happen to cortisol secretion, aldosterone secretion? There is low cortisol, low aldosterone. Okay. Now, what happens when there is low cortisol? Do you all know that cortisol in a feedback mechanism suppresses ACTH release? Do you know that cortisol in a feedback mechanism suppresses ACTH secretion? So though ACTH stimulates all three steroid hormone synthesis, ACTH stimulates synthesis of aldosterone, it stimulates the synthesis of cortisol, it stimulates the synthesis of sex steroids. But it is inhibited in a feedback mechanism only by cortisol. So in Addison's disease, when there is low cortisol, there is feedback stimulation of ACTH. And this ACTH gets released along with gamma message. Low glucocorticoid will cause feedback stimulation of ACTH, and ACTH gets released along with gamma message because both ACTH and gamma message are synthesized from a common precursor. And which is the common precursor? It is pro-opio melanocortin. So tell me, what is the significance of pro-opio melanocortin? Pro-opio melanocortin is a common precursor which synthesizes both ACTH and gamma MSH. So when there is feedback stimulation of ACTH release, along with that gamma MSH is also released, and that causes hyperpigmentation. Okay. And apart from this, when there is low cortisol, can you tell me what will happen to insulin's effects? When there is low cortisol, you know cortisol is a counter-regulatory hormone of insulin. So there is nothing to oppose insulin. So insulin's activity will be high. And high activity of insulin is the reason. High activity of insulin is the reason for hypoglycemia. And that is why I told you Addison's patient will often present with an episode of hypoglycemia. Do you understand this? Okay. And when there is low mineralocorticoid, you know, mineralocorticoid is supposed to cause sodium reabsorption. And in this case, no sodium reabsorption. So that causes hyponatremia. And this hyponatremia causes hypotension. So the carry home message here is Addison's patient will either present with an episode of hypoglycemia or they present with an episode of hypotension. Do you understand this? Addison's patient will often present with an episode of hypoglycemia or with an episode of hypotension. And when there is no aldosterone, you know, aldosterone causes sodium reabsorption. Reciprocally, it causes potassium and H plus secretion. Now, there is no aldosterone, so no potassium and no H plus secretion. So, there will be hyperkalemia and acidosis. Yeah, there will be hyperkalemia and acidosis. So, have you understood all about Addison's? Yeah, so tell me, what did you learn about Addison's? Addison's is adrenal cortical failure caused by either autoimmune destruction of adrenal cortex or tuberculosis mediated destruction of adrenal cortex. In either case, they present with an episode of hypoglycemia or they present with an episode of hypotension. Very good. So what is answer? What is the reason for pigmentation in Addison's? It's because ACTH and gamma MSH are synthesized from a common precursor which is pro-opiomelanocortin. Now this is the next question. A 5-month-old infant presented with unconsciousness which readily responded to dextrose administration. So if unconsciousness responds to dextrose administration, then what probably is the cause? It is hypoglycemia. So a 5-month-old infant is presenting with an episode of hypoglycemia. On observation, the child had a doll-like face. Do you see that the child has got a doll-like face? Doll-like face is nothing but fatty cheeks. Okay. So the child has got fatty cheeks with thin limbs and protruded abdomen. Do you see protruded abdomen? Okay. Yes. During the 2-day hospital visit, the child presented with another episode of hypoglycemia, which did not respond to glucagon administration. Ultrasound revealed hepatomegaly and renomegaly. The reason for absence of response to glucagon is. So can we summarize the positive finding here? What are the positive findings here? There is repeated episodes of hypoglycemia in an infant. Yeah, repeated episodes of hypoglycemia in an infant with abdominal distension, probably organomegaly. And it is also evident through ultrasound that there is hepatomegaly and renomegaly, but does not respond to counter-regulatory hormone administration. So what is the answer? Bhuvanashri thinks it is glucose 6-phosphatase is absent in muscle. Srujana thinks it's choice C. Glucose 6-phosphatase is involved in both glycogenolysis and gluconeogenesis. Very good. Sai Kiran, very good. Jyotirmoy, Mega, good. So what is answer here? The reason behind. So first the diagnosis here is Von Gierke's. The diagnosis here is Von Gierke. So I want you all to remember this fact. If they give you a hypoglycemia which does not respond to counter-regulatory hormone administration, if the question says there is hypoglycemia which does not respond to counter-regulatory hormone administration, your answer should be Von Gierke's disease. This is the only disorder which presents that way. And this Von Gierke's disease is caused by a defect of glucose 6-phosphatase. Von Gierke's, a type 1 glycogen storage disorder, is caused by a defect of glucose 6-phosphatase. So why should this disorder present with hypoglycemia which does not respond to counter-regulatory hormone? It is because of the way glucose 6-phosphatase acts. So tell me, glucose 6-phosphatase is an enzyme of which pathway? Yeah, One-Lee syndrome which does not respond to counter-regulatory hormone is, yes, Dinesh, you're right. So glucose 6-phosphatase is an enzyme of which pathway? It's an enzyme of not only gluconeogenesis, it's also an enzyme of glycogenolysis. So if you're asking me why should glycogenolysis be dependent on glucose 6-phosphatase, it is because glycogenolysis is done by glycogen phosphorylase, and this glycogen phosphorylase forms glucose 1-phosphate as the product. Yeah. So tell me, what is the product of glycogenolysis? Whenever you whenever you perform glycogenolysis, either in liver or in muscle, the product is not free glucose. You don't get glucose directly. The product of glycogenolysis is, first it is glucose 1-phosphate that gets converted to glucose 6-phosphate. Now, can this glucose 6-phosphate cross the cell membrane and reach the circulation? Can this glucose 6-phosphate cross the cell membrane and reach circulation? It cannot. Only when there is glucose 6-phosphatase, it can be converted to free glucose. Only that can reach the circulation. So do you all understand this? So what is the carry home message here? The carry home message here is glucose 6-phosphatase is not only an enzyme of gluconeogenesis, it's also an enzyme that is necessary for glycogenolysis to increase plasma glucose. Okay. In that case, if this enzyme is defective, don't you think the child will present with hypoglycemia? What are the two pathways by which you maintain plasma glucose in your whole body? There are only two pathways by which we maintain plasma glucose. One is liver glycogenolysis, the other one is gluconeogenesis. And both these pathways are dependent on glucose 6-phosphatase. That enzyme is defective. So this child will definitely present with hypoglycemia. And this hypoglycemia will not respond to counter-regulatory hormone administration. What is the reason? It is because whatever may be the counter-regulatory hormone that you administer, you can administer something which is as strong as glucagon, or you can administer something which is as weak as norepinephrine or cortisol, that is immaterial. And all these counter-regulatory hormones will increase plasma glucose only by stimulating glycogenolysis and only by stimulating gluconeogenesis. In a child of von Gierke's, both these pathways are defective. So there is no way plasma glucose can be maintained. And that is why if it is hypoglycemia, which does not respond to counter-regulatory hormone administration, what will be your answer? If it's hypoglycemia which does not respond to counter-regulatory hormone administration, your answer should be von Gierke's disease, which is type 1 glycogen storage disorder, which is caused by a defect of glucose 6-phosphatase. Okay. Yes. And along with this, I want you to know about other features, few other features of von Gierke's also. Tell me, if glucose 6-phosphatase is defective, what will happen to glucose 6-phosphate? If glucose 6-phosphatase is defective, glucose 6-phosphate cannot be converted to glucose. So the excess glucose 6-phosphate gets into glycolysis. What will happen when glucose 6-phosphate gets into glycolysis? It gets converted to pyruvate. Yeah, it gets converted to pyruvate. And this pyruvate gets converted to acetyl-CoA. And this acetyl-CoA will be used for fatty acid synthesis and cholesterol synthesis. And both fatty acid and cholesterol will be stored as triacylglycerol and cholesterol ester. And that is why von Gierke's disease patients present with hypertriglyceridemia and hypercholesterolemia. Do you all understand this? So what happens in von Gierke's? When glucose 6-phosphatase is defective, glucose 6-phosphate gets into glycolysis. All of you listen to this. This glucose 6-phosphate thereby gets converted to pyruvate. This pyruvate gets converted to acetyl-CoA. And this acetyl-CoA is used for what? Acetyl-CoA is used for fatty acid and cholesterol synthesis. Fatty acid is stored as triacylglycerol. Cholesterol is stored as cholesterol ester. So the child will not only present with hypoglycemia, which does not respond to counter-regulatory hormone administration. The child will also present with hypertriglyceridemia and hypercholesterolemia. And the excess triglyceride is the reason for fatty cheeks. Do you now understand the reason behind doll faces of Von Gierke's, all of you? Yeah. What is the reason for doll faces of Von Gierke's? The fatty cheek is because of triacylglycerol getting accumulated in the fat. In the adipose tissue. And the same triglyceride and cholesterol ester also accumulates in liver. And that causes fatty liver hepatomegaly. It is accumulated in kidney. So that causes renomegaly. So this is the reason for hepatomegaly, renomegaly, and doll-like phases of, that is the reason for doll-like phases of Von Gierke's. So tell me, what is answer? Why is the hypoglycemia of Von Gierke does not respond to counter-regulatory hormone administration? It is because glucose 6 phosphatase is involved in both glycogenolysis and gluconeogenesis. Okay. A 12-year-old boy presented with this, the next question. A 12-year-old boy presented with photophobia, short stature, polyuria, and polydipsia. Slit lamp examination of the cornea is shown in the image. The probable diagnosis is. So can you first describe this? If I ask you to describe this, what will be the word that you use for this? Don't you think it looks shiny? What is the treatment? You mean treatment for Von Gierke's? There is no treatment for Von Gierke's. All that you can do to support the child is to give small frequent meals or continuous intravenous dextrose infusion. Yeah, there is nothing else that can be done because repeatedly there is going to be hypoglycemia. So whenever the child presents with an hypoglycemic episode, you start dextrose. Otherwise, we keep giving, the only way plasma glucose can be maintained is through dietary glucose. It has to be given as repetitive small meals. And we have to avoid other sugars. You have to avoid in treatment of Von Gierke's. It's better if you avoid other sugars because all the other sugars will also be utilizing the phosphate. Okay, it will be utilizing the phosphate and hypophosphatemia further suppresses glycogenolysis. Do you understand this? So though I said as if I told you that glycogenolysis is totally dependent on glucose 6 phosphatase, but it's not totally dependent on glucose 6 phosphatase. Sometimes when debranching enzyme acts, a free glucose can be released. So there should be at least a minimal activity of glycogenolysis happening to avoid hypoglycemia. And for glycogenolysis, you need phosphate. And if you give any other sugar like fructose or galactose or anything else, they start trapping the phosphate and that suppresses glycogenolysis. That is why you have to avoid other sugars and give repetitive small meals as a predominantly glucose-based diet. Does that answer all your questions? Bhuvana, I just gave you the answer. Yeah. So do you see a shiny cornea here? Yeah, a shiny cornea. So we call it as, yes, you're right. Yeah, fructose has to be avoided because it causes phosphate trapping and phosphate trapping will inhibit glycogenolysis. So even the direct glucose that we get is not, okay, good. So you all understood. So we call it a sequin. Yeah, we call it a sequin-like crystals in the cornea. Yeah, sequin or glittery. Yeah, sequin or glittery or shiny crystals on the cornea. That is quite diagnostic of cystinosis. Yeah, this is quite diagnostic of cystinosis. Can we exclude all these choices? Can it be Hartnupp's disease? Can this be Hartnupp's disease? What is Hartnupp's disease, all of you? Hartnupp's disease is caused by a defect of a neutral amino acid transporter, which is specific for tryptophan. Yeah, it's caused by a defect of a neutral amino acid transporter that is specific for tryptophan. And that neutral amino acid transporter is responsible for both tryptophan absorption along the intestine as well as for tryptophan reabsorption along the renal tubules. So when this transporter is defective, very good. When this transporter is defective, tryptophan cannot be absorbed along the intestine. So tryptophan deficiency will cause niacin deficiency. We know tryptophan is a precursor of niacin. Without tryptophan, there will be no niacin. So niacin deficiency will present as 3 Ds of pellagra. They will present with photosensitive dermatitis. Yeah, dermatitis, dementia, and diarrhea. Diarrhea, dermatitis, and dementia. And along with that, the same transport is also responsible for tryptophan reabsorption along the renal tubules. So when there is no reabsorption of tryptophan along the renal tubules, all tryptophan will be lost in urine. Anything which has entered into the circulation will be lost in urine. So there will also be amino aciduria. Very good. Yes, in 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So if you see 3Ds of pellagra with amino aciduria, then that is Hartnupp's disease. Yes, blue diaper is also a feature. Very good, Dinesh. So the reason for blue diaper is in Hartnupp's disease, tryptophan is found in urine. And when this urine gets exposed to air, the indoor ring of tryptophan will get oxidized to form ketol compounds. Yeah, when this urine gets oxidized, when this urine gets exposed to air, the indole ring of tryptophan will get oxidized to form ketol compounds. And these ketol compounds are blue in color. And that is why it is called as blue diaper syndrome. Okay, so Hartnupp's disease will also present as blue diaper syndrome. So what are the facts that you've learned about Hartnupp's disease? It will present as 3Ds of pellagra with amino aciduria with blue diaper syndrome. Okay. So we have excluded Hartnupp's disease. Can it be homocystinuria? No. What did I tell you about homocystinuria in just few questions back? Yeah, I said homocystinuria will present as accelerated atherosclerosis. It presents as accelerated thrombosis. They present with ectopia lentis, right? And they present with skeletal deformities. So young stroke, young MI, flat foot, Charlie Chaplin gait, spontaneous dislocation of lens. So all these will guide you towards, yes, infranasal dislocation. Only that will make you a that will help you make a diagnosis of homocystinuria. Here, you don't find any such features. Okay. And can it be cystinuria, all of you? We discussed about cystinuria also. What did I tell you about cystinuria? Hexagonal crystals. It will present as recurrent renal stones. They will just present as recurrent obstructive uropathy. So this is not cystinuria as well. So what are you left with? You're only left with cystinosis. So what is your diagnosis here? Your diagnosis here is cystinosis. So let me tell you all that you need to know about cystinosis. Cystinosis is a lysosomal storage disorder. Yeah, what is it? It's a lysosomal storage disorder wherein there is defective efflux of cysteine from lysosomes. So do you know whenever a protein's lifespan gets over, yeah, whenever a protein's lifespan gets over, these proteins get degraded by proteases within lysosomes to give rise to individual amino acids. Then these individual amino acids come out of lysosomes and then they get into mitochondria. After they come out of lysosomes, these amino acids should get into mitochondria because only in mitochondria these amino acids can be oxidized. Now, what is cystinosis? Cystinosis is caused by defective efflux of cysteine from lysosomes. So, cysteine accumulates within lysosomes. On chronic accumulation of cysteine within lysosomes, there will be lysosomal degranulation. And lysosomal degranulation will cause local tissue damage. And when local tissue damage happens in proximal convoluted tubule, when PCT is damaged, do you know most of the solutes get reabsorbed in PCT? All of you? Do you know that most of the solutes get absorbed in PCT? So PCT fails to reabsorb all these solutes. So what you would find is glycosuria, amino aciduria, phosphaturia. Phosphaturia will cause short stature. Okay. Bicarbonaturia will cause renal tubular acidosis. Polyuria, polydipsia. Collectively, that is called as Fanconi syndrome. Yeah, so tell me, why do you find Fanconi syndrome in cystinosis? Chronic accumulation of cysteine in lysosome will cause lysosomal degranulation. And when degranulation happens in proximal convoluted tubule, there is PCT damage. So there is no glucose reabsorption. Yeah, there is no glucose reabsorption, no amino acid reabsorption. So what will you find? You'll find glycosuria, amino aciduria, phosphaturia. And when phosphate gets lost, there is no phosphate in circulation. That is why the child will present with short stature. When bicarbonate is lost in urine, there is no buffer that causes renal tubular acidosis. Only along with these solutes, water also gets reabsorbed. So no water reabsorption that that causes polyuria, polydipsia. And this is collectively called as Fanconi syndrome. And this local tissue damage does not only happen in PCT, it also happens in iris. When iris gets depigmented, do you all know that iris acts as the diaphragm of your eye? You know that, right? Iris acts as a diaphragm of your eye because it's pigmented. And this local tissue damage happening in iris will not allow it to act as a diaphragm. So all light will get into the eye. So the child will complain of photophobia. Yeah, Fanconi syndrome, photophobia. So whenever you find a child presenting with polyuria, polydipsia, short stature and photophobia, do a slit lamp examination of the cornea. And cornea will show characteristic sequin-like crystals. Yeah, cornea will show characteristic sequin-like crystals, and that is cystinosis. So have you understood all of this? So what is the probable diagnosis here? The probable diagnosis here is cystinosis. So this is the last question for today. An infant presented with watering of eye, incessant cry, and on observation, you find tiny erosions. Yeah, you find tiny erosions of the eye. The pediatrician also observed a rough palm in the infant. Yeah, rough palm in the infant. The probable diagnosis is it type 1 tyrosinemia, type 2, type 3, or alkaptonuria? Can anybody try answering this? There are eye lesions and there are skin lesions. So eye and skin lesions, can you call it as oculocutaneous syndrome? Yeah, there are eye lesions and skin lesions, can we call it as oculocutaneous syndrome? And how many eyes do you have? Yeah, 2 eyes. And what is it? It is type 2 tyrosinemia. Yeah, oculocutaneous syndrome is nothing but type 2 tyrosinemia. So let's learn about type 2 tyrosinemia now. Type 2 tyrosinemia is caused by a defect of tyrosine transaminase. Tell me how many T's are there? Tyrosine transaminase, how many T? 2 T's. Yeah, just remember that. Type 2 tyrosinemia is caused by a defect of 2 T. What are the 2 T's? Tyrosine transaminase. The other two related to this is oculocutaneous syndrome. It's otherwise called as oculocutaneous syndrome. Oculo because it presents with spontaneous corneal erosions. Yeah, oculo because it presents with spontaneous corneal erosions. Cutaneous because it presents with palmar hyperkeratosis. Yeah, that is why it was described as thick palm skin. Yeah, palmar hyperkeratosis is oculocutaneous syndrome or type 2 tyrosinemia. It is otherwise called as Richner-Hanhart syndrome. Okay, it's otherwise called as Richner-Hanhart syndrome. Now, for completion's sake, let me tell you about type 1 tyrosinemia. Type 1 tyrosinemia is caused by a defect of the last enzyme of tyrosine metabolism. And it is fumarate acetoacetate hydrolase. Dinesh, thank you. Yeah. So type 1 tyrosinemia is caused by a defect of the last enzyme of tyrosine metabolism. It is fumarate acetoacetate hydrolase. And when fumarate acetoacetate is defective, when fumarate acetoacetate hydrolase is defective, fumarate acetoacetate accumulates that gets converted to succinyl acetone. So whenever the question says, yeah, the question, it can give you any clinical feature, any biochemical feature. But if you see the term succinyl acetone, yeah, if you see the term succinyl acetone, immediately choose type 1 tyrosinemia. Okay, succinyl acetone is pathognomonic of this condition. And this succinyl acetone is toxic to liver and renal parenchymal cells. And that is why it is called as hepatorenal syndrome. Yeah, that is why type 1 tyrosinemia is otherwise called as hepatorenal syndrome. So why hepatorenal? What are the findings related to liver? The child will present with jaundice, yeah, because liver parenchymal cells are damaged. The child will present with jaundice, with hepatomegaly, sometimes even cirrhosis, and it can even progress to hepatocellular carcinoma. So if the history says a boy, say 8-year-old boy or a 10-year-old boy presents with a massive elevation of alpha fetoprotein, ultrasound reveals liver primaries, yeah, or some investigation reveals liver primaries. So hepatocellular carcinoma in a small child, yeah, immediately what should be your answer? Your answer should be type 1 tyrosinemia. So it can even cause hepatocellular carcinoma. Renal, because why do you call it as renal syndrome? Because it presents with Fanconi syndrome. It can progress to renal failure. So that's about type 1 tyrosinemia. So tell me about type 1 tyrosinemia. I said type 2 tyrosinemia is tyrosine transaminase defect. Type 1 tyrosinemia is caused by the defect of the last enzyme of tyrosine metabolism. It is fumarate acetoacetate hydrolase. Yeah, type 1 tyrosinemia is characterized by cabbage odor of the urine. It is characterized by cabbage odor of the urine. Okay, so succinyl acetone accumulates, that is toxic to liver and renal parenchymal cells. So it presents as hepatorenal syndrome, jaundice, hepatomegaly, hypoglycemia, liver cirrhosis, hepatocellular carcinoma, Fanconi syndrome, and renal failure. But irrespective of all these findings, if the history says succinyl acetone is elevated, what will be your answer? The moment you see succinyl acetone, your answer should be type 1 tyrosinemia, and it's characterized by cabbage odor of the urine. Okay. So what is the answer here? The answer here is oculocutaneous syndrome. So it is type 2 tyrosinemia. Now type 3 tyrosinemia, yeah, type 3 tyrosinemia is caused by a defect of para-hydroxyphenyl pyruvate dioxygenase. Type 3 tyrosinemia is caused by a defect of para-hydroxyphenyl pyruvate dioxygenase, and it causes intermittent ataxia. What does it present as? It presents as intermittent ataxia and seizures. Okay, and this is caused by low activity of para-hydroxyphenyl pyruvate dioxygenase. Whereas when para-hydroxyphenyl pyruvate dioxygenase is hyperactive, when there is hyperactive para-hydroxyphenyl pyruvate dioxygenase, you call it as Hawkinsinuria. Yeah, what will you call it as? You will call it as Hawkinsinuria. And this Hawkinsinuria is caused by a this Hawkinsinuria is characterized by swimming pool odor. It is characterized by swimming pool odor. Okay. So tell me just the names. Type 1 tyrosinemia is caused by an enzyme defect, which is fumarate acetoacetate hydrolase. Type 2 tyrosinemia is tyrosine transaminase defect. Type 3 tyrosinemia is caused by a defect of para-hydroxyphenyl pyruvate dioxygenase. Hyperactivity of that enzyme causes Hawkinsinuria. Okay. So can we close the session for today? Yeah. So the remaining we'll discuss in the next class. So see you all with another session. Probably I will meet you all with a case-based MCQ discussion later on. Or tomorrow I'll have a session. Tomorrow around the same time at 8 o'clock, I have another session. I will share that in the group. Yes. Yes, hawk flying over the swimming pool. Yes. Okay, so thank you all. I will share the PDF in the Telegram group. Download it, revise and memorize all the facts that we have discussed today. Good night. My pleasure, Megha.